Can you see it now, Kirsty? If not, I'll just set up an. I've opened. Yeah, I can see Gerard wanting to join. Okay, so yes. Okay, I can see the waiting room now, Kirsty. Yeah, because Crystal, Shanae, Gerard. Yeah, 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 yeah. Okay, yeah, no problem. Okay, yeah, thank you. Okay, Kirsty, I think most of us who could join on time are here. You can start sharing your screen, and then we'll start in a second. Okay, Kirsty, it's already 15 minutes delayed, so you can start. So today, Dr. Kirsty Pedersen is giving us a talk on childhood sepsis. She has studied extensively and is going to give us a lot of interesting information. Kirsty, all yours. We will have to stop in just about 25 minutes to enter into the next meeting. Okay, Kirsty, you can go.
Hello, can everyone hear me now?
Yes, yes, we can hear you.
Sorry, Prof, I got muted. Okay, so today's talk will look at a quick introduction, some looks at a quick glance at the immune system, septic markers, blood culture. Then the main focus of this talk was to look at the new Surviving Sepsis Campaign international guidelines that came out, and these ones are specified to children compared to the old ones that were for adults. And then a quick touch on antibiotic stewardship, our antibiotic guidelines, some long-term outcomes of these patients, and then some resources. On the right is everything that's included in the guidelines. Sorry. So sepsis has a high prevalence worldwide as well as locally in the patients that we see. This can be either community-based infections or hospital-acquired. It has a high morbidity and mortality rates and places a high demand on our resources. So the prevalence of severe sepsis worldwide is about 8.2%, with an associated mortality rate of 25%, which is quite high for sort of any condition that we see. And that 25% showed no difference between developing and developed countries, which I found was quite interesting. Mm-hmm. In our department, about 35 to 40% of our admissions each month are sepsis related. such as appendicitis, abscess, cellulitis, or EC. Oh man. Sorry, now it's not showing me my. Sorry, it's not giving me my notes. I don't know why it's doing this. Okay, I'll just try to talk without them and try to remember what I had written down. Okay, so in our immune system, a pathogen is presented initially to our natural barriers, such as the skin and respiratory tract and the gut. These areas contain malt, so initial barrier. If a pathogen gets past that, it comes into contact with our immune system. So the body can either mount an immune response or have no response if it's a pathogen that's become tolerated. The immune response is then split into innate immunity or adaptive immunity. So innate immunity is an immediate response. It's non-specific to the pathogen, and it doesn't have any memory. It's mostly mediated by the B cells. This can result into phagocytosis or an inflammatory response with the elimination of the pathogen. And then the adaptive immunity is a much slower response, but it is specific to certain pathogens. This is mediated mostly by the T lymphocytes and antibodies, and has the ability to maintain memory of a pathogen seen, which allows for a much better and more effective response for any further exposure to that pathogen. Adaptive immunity can be split into humoral or cell-mediated immunity, and it results in phagocytosis with pathogen elimination, that formation of memory, and then immunopathologies can exist. So immune deficiencies can either be primary or secondary. So primary is an inherited immune deficiency from a genetic mutation. So it can be a combined immunodeficiency where both B and T cell function is defective, or SCID, which is severe combined immunodeficiency. This is very rare, but a very serious condition. They lack T cells and have a very number of B cells, which results in little to no immune function. Other primaries is B cell immunodeficiencies, T cells, phagocyte disorders, or complement defects. These are managed by bone marrow transplant, vaccinations, and herd immunity, or immunoglobulin replacement therapy. And then secondary immunodeficiency is acquired immunodeficiency, such as HIV, or due to malnutrition, or due to medical treatment, such as chemotherapy or medication received after transplant. So looking at the definitions of sepsis, this is currently a hot topic in the research. For a long time, there weren't specific definitions for sepsis, especially when it comes to pediatric patients. But in 2005, the International Pediatric Sepsis Consensus Conference was held to come up with the definitions. So this set of definitions is the only widely accepted pediatric definitions for sepsis. However, it was designed for research purposes primarily. So this has an unknown implication in terms of clinical practice, and there are currently studies going on into how these definitions match up with our clinical management of patients. So SIRS is a systemic inflammatory response syndrome. This is defined as the presence of at least 2 of the following 4 criteria, one of which must be an abnormal temperature or elevated leukocyte count. So in children, a child can have an increased respiratory rate or increased heart rate due to many other varied causes. So that's why it has to be an abnormal temperature or a white cell count has to be included in the criteria. So it's a core temperature of more than 38.5 degrees or less than 36 degrees. if you suspect that especially in a neonate, that the child's temperature is high due to being bundled, they suggest unbundling the child for half an hour and then repeating the temperature. You can have an elevated or depressed white cell count, tachycardia or bradycardia, especially in the children under 1 year old, and then tachypnea. So at the end of this talk, there's the resources has all the age-adjusted parameters for those vital signs. So sepsis is defined as SIRS associated with a suspected or proven infection. Obviously bacterial, viral, fungal, or rickettsial infections. And then severe sepsis is defined as sepsis plus one of the following. So cardiovascular organ dysfunction or acute respiratory distress syndrome or 2 or more other organ dysfunctions. So the definitions of the organ dysfunction. So cardiovascular will have hypertension, the need for inotropes, a metabolic acidosis, a high lactate, low urine output, prolonged capillary refill time, or cool peripheries. Acute respiratory distress syndrome has to have hypoxia with bilateral infiltrates on chest x-ray, an acute onset, and not be due to left heart failure. Other signs of respiratory failure might be hypoxia, hypercapnia, requiring more than 50% FiO2 to maintain saturation, and then the need for ventilation. Renal, seen with a rise in creatinine. Neurological is defined as a GCS less than 11, or an acute deterioration in the presenting GCS to the current GCS of more than 3. Hematological thrombocytopenia, or a drop in platelets of 50% in the last 3 days, or raised INR more than 2. Then hepatic is seen with a raised ALT or raised total serum bilirubin. So septic shock is still currently debated. The actual definition of it isn't very clear just yet. So it's defined as severe sepsis with cardiovascular dysfunction. So some definitions included tachycardia with signs of decreased peripheral perfusion. As in children, the hypertension is normally a very late sign of cardiovascular dysfunction. And then other publications include the need for inotrope support in the definition of septic shock. Multi-organ dysfunctional failure. This was actually left off the latest guidelines, but was included in the guidelines from 3 years ago. So according to those, it's defined as the presence of altered function affecting more than one organ, be maintained without intervention. And then MODS, the syndrome, which can either be primary, directly due to sepsis, or secondary due to the host response to the sepsis. So a quick look at septic markers. Septic markers can either be diagnostic or for monitoring for stratification of risk, or a surrogate marker. So the two that are currently most widely known is the CRP, C-reactive protein, and procalcitonin. So C-reactive protein is an acute phase reactant produced during infection or tissue injury. This increases within 46 hours after the insult and doubles every 8 hours after that. It's got a poor specificity for infection, so therefore it does not differentiate between different infectious agents. So it does not help to make the diagnosis between certain therapy, and in our setting is readily available and relatively inexpensive. Procalcitonin is the latest kid on the block. So it's a precursor for calcitonin. It's normally produced by the thyroid, but all other tissues in the body have the ability to produce procalcitonin. So in children with sepsis, and especially in bacterial infections, the other tissues produce procalcitonin, which shows a raise in the blood levels. Its response to infection and the resolution of the procalcitonin back to normal is much quicker than that of CRP. So it allows for better differentiation between SIRS and sepsis. It's an excellent marker for monitoring antibiotic response as well as for prognosis. And then it's just less specific in neonates. Just to briefly mention a few others that are up and coming. CD64 There's a receptor on the neutrophils. It's upregulated when there's an infectious agent. However, it does not clinically perform better than CRP and PCT, so it can be used as an additional aid in diagnosis. Interleukin-18 is produced by activated macrophages. There's been a few small studies, but these have shown no diagnostic ability. Lactate is a surrogate marker as an indication of tissue hypoxia. This can help you differentiate between sepsis versus septic shock. And then the time that it takes for the lactate to normalize is prognostic. They haven't come up with an exact limit for or number for the lactate in pediatrics, but the adults use, if lactate is more than 2, then it's defined as septic shock. And then just others is your ESR, interleukin-6, as well as your base sticks. So quick look at blood cultures, indications if there's clinical features of sepsis, if you suspect a localized infection, suspicion of infective endocarditis, if you have a pyrexia of unknown origin, or an unexplained abnormal white cell count, then a blood culture can be indicated. So aerobic blood culture bottles in pediatrics grow most medically important bacteria, fungi, as well as anaerobes. So there's no need to use an anaerobic bottle in addition. False positive results can occur when a skin commensal is involved, so your sterile technique is really important. It is best taken when the patient is currently pyrexial. It requires 1 to 5 mL of blood. The greater the results yield is. They suggest an ongoing sepsis that 2 samples be taken either 12 to 24 hours apart. And if a sample is taken from a central line, then it's recommended to take a peripheral sample at the same time. And then they've said that more than 3 blood cultures for a patient showed no improved yield unless there was intermittent bouts of sepsis. So if you've had 2 samples taken 12 to 24 hours apart, there's very little use in taking a 3rd or 4th. So coming to the guidelines, what I did for these guidelines is they're quite extensive. So I've taken out all the summaries for them into this PowerPoint. So if anybody wants the full notes, you're welcome to pop your email address to me. But we'll obviously, for the sake of time, we'll skim through them and just highlight the important bits. So in 2001, the Surviving Sepsis campaign was formed with a whole lot of really big, important players. The objective was to create a comprehensive evidence-based recommendations for the recognition and management of children with septic shock or other sepsis-associated acute organ dysfunction. They looked at children was defined as a neonate to 18 years old, and they're busy developing guidelines for resource-restrained settings, which will differ slightly. So all the recommendations are classified as either a strong recommendation where they had good evidence-based. We'll start with we recommend. And if there was weak evidence-based recommendations, it will start with we suggest. So they made a big point in the introduction to say that these are guidelines for best practice, but not specific rules or set out steps as to how people should follow. So it's still very much up to the clinician. This just sort of pulled all the latest evidence-based recommendations together. So as I said, sepsis is a leading cause of morbidity and mortality for children worldwide. Majority of death from sepsis is due to shock or multi-organ dysfunction. This occurs initially in the first 48 to 72 hours of sepsis. It highlights the importance of early identification and early and appropriate resuscitation and management. So when it comes to screening and diagnosis, we recommend implementing a protocol guideline for the management of children with septic shock. We recommend obtaining blood cultures before initiating antimicrobial therapy in situations where this does not delay antimicrobial administration. In children who present acutely unwell, they suggest implementing a systematic screening tool for timely recognition of septic shock. And in our practice, blood lactate levels can be used as an indirect marker for tissue hyperperfusion, as mentioned. So looking at antimicrobial therapy, In children with septic shock, they recommend starting antimicrobial therapy as soon as possible. Within 1 hour of recognition should be the goal. In children with organ dysfunction and sepsis, but not in shock, we suggest starting antimicrobial therapy within 3 hours. This allows for a little bit more time for better evaluation and diagnosis. And they recommend starting an empiric broad spectrum therapy with 1 or more antimicrobials as needed to cover all likely pathogens. So definitions when it comes to antimicrobial therapy: can have empiric antimicrobial therapy. This is normally initial therapy that's started for a suspected infection in the absence of definitive microbiological pathogen identification. It can be either single, multiple agents. It should be broad spectrum in nature. And it's best to try and limit it to a single agent if possible. And then your empiric therapy should be based on local pathogens and epidemiology that's seen in your area, as well as patient risk factors. And then targeted or definitive therapy is antimicrobial therapy targeted to a specific pathogen. This is normally after it's been identified through a blood culture or pus swab, etc. Again, it could be single, multiple. However, it should not be broader than is required to treat the pathogens that have been identified. So some considerations when it comes to antimicrobial therapy: in immunocompromised patients and preterm infants, to think of fungal infections. Patients at risk for an atypical or resistant pathogens may be neutropenic patients, the neonates, and then children with chronic conditions that are treated in hospital settings often may have an MRSA or a vancomycin-resistant enterococci, so a hospital bug. So general suggestions when it comes to therapy: previously healthy children with community-acquired sepsis should be treated with a third-generation cephalosporin. Vancomycin can be added when MRSA is very prevalent. And then an aminoglycoside or carbamazepine is appropriate in settings where ceftriaxone resistance is high. For immunocompromised patients or hospital-acquired sepsis, they suggest a third or higher generation cephalosporin, a broad spectrum carbapenem, or an extended range penicillin or beta-lactamase inhibitor such as piptazepam. For patients that the suspected or documented intra-abdominal source, they suggest again an extended range penicillin, carbamazepine, or then the addition of clindamycin or metronidazole. And if you suspect toxic shock syndrome or necrotizing fasciitis, then they suggest the addition of clindamycin to limit toxin production. So once the pathogens and sensitivities are available, we recommend narrowing empiric antimicrobial therapy coverage. So they say within no more than 48 hours after starting empiric treatment, you should reevaluate your choice of treatment. So, to see if your treatment is correct and if your cultures have grown anything to direct targeted treatment. If no pathogen is identified, we recommend narrowing or stopping empiric antimicrobial therapy according to the clinical presentation of the patient and the suspected infection. In children without immune compromise and without risk for multi-drug resistant pathogens, we suggest against the routine use of empiric multiple antimicrobials. So again, one is better than many if it is possible. However, if it is in an immune compromised child with high risk for multi-drug resistant pathogen, then an empiric multi-drug therapy when there's septic shock present is suggested. We recommend using antimicrobial dosing strategies that have been optimized based on published pharmacodynamic principles. So in children with septic shock, they recommend daily assessment for de-escalation of antimicrobial therapy, and we recommend determining the duration of the antimicrobial therapy according to the site of infection, response to treatment, as well as the pharmacological guidelines. So just to summarize all of those, in septic shock, you want to aim to start antibiotics within 1 hour. Without shock, and allows for time for evaluation, but to start antibiotics within 3 hours. Initially use an empiric broad spectrum therapy with one or more antimicrobials to cover all likely pathogens. When you consider the pathogen, you need to look at patient's age, the clinical picture, any known local pathogens. To reevaluate your empiric antibiotics after 48 hours and narrow the antibiotics or stop them as required. Make sure you're using the correct dosing as well as timing of the antibiotics. So source control, we recommend that emergent source control intervention be implemented as soon as possible after diagnosis of an infection. We recommend the removal of intravascular access devices that are confirmed to be the source of sepsis or septic shock after other vascular access has been established. Fluid therapy, this is quite a lot. I'm not going to go through all of it. So they suggest administering 40 to 60 mL per kg in bolus fluids in 10 to 20 ml boluses over the first hour. And then they define it according to different settings. I just want to focus on the last one because that's the one that really applies to us. In low resource settings, the WHO recommends 10 to 20 mL per kg of isotonic crystalloid over 30 to 60 minutes, followed by an additional 10 mL per kg of signs of fluid overload or cardiac failure or neurological deterioration have developed, then you need to stop giving fluid boluses. Then something that we sometimes struggle with in our department, so I just want to do pause on this, is the alternative methods of vascular access. So if initial attempts at a peripheral vein cannulation are not immediately successful, these are your other options. So intraosseous access is rapid and effective, otherwise an umbilical venous catheter in a neonate. Then you can do an ultrasound-guided peripheral IV catheter placement. You can do a central venous catheter, either as a push-in, ultrasound-guided, or cut-down. You can use an internal or external jugular vein, subclavian vein, femoral vein, or greater venous vein. So just to look at intraosseous vascular access, you want to, in an infant, you want to feel for the tibial tuberosity, and then 1 centimeter below and 1 centimeter medial is where you want to insert the interosseous, and you insert it at a 90-degree angle to the skin. And then you can see in the adolescent it's similar. Other places you can insert it, especially in older children, is the anterior superior iliac spine or the distal tibia 2 centimeters above the medial malleolus. So the importance of this is to not waste time struggling with the peripheral line. And intraosseous is a quick insertion and gives you vascular access for 24 hours. You can give resuscitation fluids, you can draw bloods and blood culture from it, or give blood products if needed, and many medications can be given through this intraosseous vascular access. So it buys you time to stabilize the patient, get them fully resuscitated, and then obviously time to get a better peripheral line. And then for the umbilical vein catheterization, this can be done up until day 14 of life. At that stage, if the umbilicus is mummified at the tip, you might just need to cut it. As you can see, there are 2 umbilical arteries and 1 umbilical vein. Is normally at the 12 o'clock position, and is dilated with floppy edges compared to the hard arteries. So in an emergency situation, an umbilical catheter should be inserted for 1 centimeter past where you get blood drawn back. So this is normally 4 to 5 centimeters in a term infant. If you want to leave it in for longer duration, it should be inserted about 10 to 12 centimeters in a term infant. You ideally want it to lie in the inferior vena cava just below the right atrium. And this can be checked with a chest or abdominal x-ray after insertion, chest x-ray. These can be left for up to 14 days as long as they are kept sterile, and again can be used for anything that's needed. It is contraindicated for umbilical or abdominal wall defects. So we suggest using crystalloids rather than albumin for initial resuscitation. That was a comment on the adult guidelines that suggest albumin much more regularly. We suggest using a balanced or buffered crystalloid such as Ringer's lactate or plasmonite rather than normal saline for initial resuscitation boluses. We recommend against using starches or gelatin. So in summary, for fluids, get IV access quickly. Do not delay in inserting an intraosseous line or an umbilical line if you're struggling peripherally. Give a fluid bolus of 20 ml per kg over 30 minutes, preferably with Ringer's lactate or plasmonite. If this is not available, then use normal saline. This bolus can be repeated up to 3 times if no signs of fluid overload. So hemodynamic monitoring, again, I'm not going to go through all of it. If you're interested, you're welcome to read about it. So they don't recommend aiming for a specific mean arterial pressure, but rather just to make sure that the child is perfusing. The warm shock versus cold shock that was quite prevalent in the adult guidelines has now fallen away. Yeah, and then they just again use the trend of blood lactate levels as a surrogate marker for tissue perfusion. So beta-active medications, again, another thing that's often a topic of debate in our department, so I thought I'll just pause here. So the blood pressure is the product of cardiac output and the systemic vascular resistance. So we use adrenergic receptors. So the alpha-1 adrenergic receptors causes vasoconstriction, which causes an increase in the systemic vascular resistance. You can see that on the left of the curve. Beta-1 adrenergic receptors cause an increased contraction of the cardiac muscles, as well as an increased heart rate, which then increases the cardiac output. So that's on the right. Then as you go around the curve, you can see that epinephrine or adrenaline for us is more of an alpha-1 causing vasoconstriction. Dopamine has action on both the alpha-1 and the beta-1. So at low doses, it affects the beta-1, causing an increased cardiac output. But at higher doses, dopamine causes vasoconstriction and acts more like adrenaline. So depending on what your desired effect is, you can adjust the dose and concentration as required. And then dobutamine mainly acts on the beta-1 receptors. So that's more effective on the cardiac function, more than vasoconstriction. So the guidelines, we suggest using epinephrine or adrenaline rather than dopamine in children with septic shock. They're unable to issue a recommendation for a specific first-line vasoactive agent. However, in their practice, they normally select ephedrine or norepinephrine as the first line. And then they're unable to use vasoactive agents through a peripheral access. However, in their practice, they do as needed. So then I thought I'd just bring up, this was a double-blind randomized clinical trial that looked at children who were in ICU for 3 months, from the age of 3 months to 12 years. Adrenaline as a first-line vasoactive therapy in treatment of shock. So all of these children were children that had septic shock and needed inotropes and were ventilated. So the resolution of shock within the first hour was achieved in a greater proportion of children that received epinephrine rather than dopamine. And this trend persisted even at 6 hours on inotropes. Epinephrine had less organ dysfunction associated with its use, and there was no difference in the adverse events or mortality. So this is a study that the guidelines quote in suggesting that we start with adrenaline as a first line rather than dopamine. So we suggest either adding a vasopressin in children with septic shock, such as dobutamine, that can be added. And then we don't really use dilators in our kids. So in looking at ventilation, they were unable to recommend about whether to intubate children with severe septic shock. However, in their practice, they commonly do intubate them, even if they don't have signs of respiratory failure. They suggest not to use etomidate when intubating children, as it has shown a risk of adrenal insufficiency. So they suggest using ketamine and fentanyl. These are easily available and have a more favorable hemodynamic profile in terms of an anesthetic for intubating. And then they suggest a trial of non-invasive mechanical ventilation in children with ARDS rather than mechanical ventilation straight away. So try a trial of CPAP before intubating, such as there. And then they also say that a trial of prone positioning, so putting the child in prone position for at least 12 hours a day or as tolerated, can also help with ARDS in children. Recommend against the use of inhaled nitric oxide and only using that as a rescue therapy. They're unable to recommend about oscillation. However, again, that's up to the clinician's decision. And we suggest using a neuromuscular blockade in children with severe sepsis and ARDS. This can be used for 24 to 48 hours to help with ventilation. Hydrocortisone to treat children with septic shock. If fluid resuscitation and inotrope therapy are able to restore hemodynamic stability. However, in the children that aren't responding to inotropes or fluids, it's up to the clinician's decision whether to use corticosteroids or not. So the upside to can help with the cardiac output as well as oxygenation to the cardiac muscles. So it almost works the same way as dobutamine does. However, it has a negative effect on the immune system, so it can put them at greater risk of hospital-acquired infections. So on endocrine metabolic, we recommend against using insulin therapy to maintain a blood glucose target. So their consensus is to target a blood glucose level below 10 in septic children, but there was no consensus on what the lower limit of acceptable would be. And then they can't recommend about targeting normal calcium levels. However, if it is possible to correct it, one should. And they suggest against using levothyroxine, and then you can have, they say we suggest either antipyretic therapy or permissive approach to fever in children with septic shock, so to not be too worried about managing it extremely closely. In nutrition, there's quite a lot of guidelines. The end point of it all is to not withhold enteral feeding, solely on the basis of the child being very sick or on inotropes. So they try to start enteral nutrition as soon as possible in these children. And then obviously they suggest using a nasogastric tube rather than a post-pyloric feeding tube. And against adding any other special supplementations, as well as suggest against the use of prokinetic agents or multiple vitamin supplementations. Professor, you're running short on the time. Should I pause here?
Yeah, sorry, because yes, we will pause here. I'll end this meeting and I'll start the next meeting because we're just about 1.5 minutes left. Okay.
Sure.
Yeah. So I just put it on the chat. Kirsty, you can start sharing your screen again.
Is everybody back?
Yeah.
So, sorry, it's just coming to the end of the guidelines. So the blood products, they suggest against transfusion of red blood cells if the hemoglobin concentration is greater or equal to 7, which is what we currently also follow. They do not have a recommendation for unstable children with septic shock in regards to transfusion. And then they suggest against prophylactic platelet transfusion based slowly on platelet levels in non-bleeding children. And then we suggest against prophylactic plasma transfusion in non-bleeding children with septic shock. Relevant to us because we don't have any of these things, but it is forms a good part of the guidelines. So it suggests against the routine use of IV immunoglobulins. In terms of prophylaxis, they suggest against the routine use of stress ulcer prophylaxis in critically ill children, as early, again, to stress the importance of early enteral nutrition forms a viable alternative to this. And we suggest against routine DVT prophylaxis, especially in children, unless there is a specific risk in that clinical patient. So to summarize all of their guidelines, they have this initial resuscitation algorithm. So if you assess the child as having septic shock, within the first hour, you want to get the following 6 steps done. Obtain IV or intraosseous access, collect a blood culture, start the empiric broad spectrum antibiotics, take a measurement of lactate, administer fluid boluses if shock is present or as needed, and start a vasoactive agent if shock persists after fluid bolus. And then if sepsis is suspected, again, you have the window of 3 hours to expedite diagnostic evaluation. And if that evaluation does support a sepsis-associated organ dysfunction, continue with the 6 steps. And obviously, if the child develops shock, to then hasten the procedures. So once the child is settled, assess the need for respiratory support, and assess for ARDS. And then there'll be a continuous reassessment of infectious source control, fluid and vasoactive titration, and then advanced hemodynamic monitoring, which we unfortunately don't have. And then at the bottom, again, it's up to the clinician's choice if you want to give hydrocortisone for refractory shock, to look at nutritional support and starting enteral feeding early, avoid hypoglycemia in these patients, and then look at antimicrobial stewardship, which we will get to. So in terms of antibiotic stewardship, the WHO has come up with a resolution that they've termed combating antimicrobial resistance, including antibiotic resistance. They found that the main driver for antimicrobial resistance was inappropriate overuse of antibiotics. This practice spans all sectors of healthcare, and they found the biggest culprit is empiric antibacterial prescribing for undifferentiated fever, such as then prescribing an antibiotic for a patient with a viral infection. So the steps that are set out from the WHO is to enable appropriate prescribing, such as with improved diagnostic point of care, identifying microbes and its resistance profile, development of laboratory infrastructure and services to allow us to strengthen our surveillance, improve the access to appropriately prescribed antimicrobials, with a focus on education and evidence-based guidelines, disincentivize inappropriate prescribing. This is mostly in private, where remuneration is linked to prescriptions. Look at new models of antimicrobial research and development, as well as the pricing of drugs, and recognize that it involves both human and animal health and requires a coordinated collaboration between the two. Looking then at South Africa's, this was already in 2014 when this article was written, but they already noted we have Klebsiella pneumonia that is already resistant to colistin, which is our last antibiotic for gram-negative organisms currently, as well as having Canada that's resistant to fluconazole, and new drugs expect to take 10 to 15 years before they'll be in circulation. We also have multi-drug resistant TB, drug-resistant HIV, as well as drug-resistant malaria. So it's definitely a big problem in South Africa. And I really enjoyed this quote from Mark Mendelson, who's one of the bigger names in antibiotics. This problem, it's personal and it's here to stay. So if we don't do something about it now, our patients' morbidity and mortality will increase substantially. So in South Africa, as a response to the WHO, they formed the South African Antibiotic Stewardship Program, which has led the introduction of stewardship to promote appropriate antimicrobial prescribing across both public and private health sectors. And their interventions have had quite a lot of positive results. So their strategy rests on 4 pillars of governance, surveillance and reporting, antimicrobial stewardship programs, and infection prevention and control. So they've come up with the principles for rational antibiotic prescribing. So these are ways that you can be a good antibiotic steward. So the first one is to decide if an antibiotic is indicated. So does this patient have a bacterial antibiotics in a hospitalized patient or in outpatients that have recurrent infections? And then to choose an appropriate empiric antibiotic. So target the most likely pathogen for the site of infection. So if it's an infection of skin or soft tissue, this will be gram-positive cocci. If it's a UTI, it will be gram-negative bacilli. If it's intra-abdominal infection, it can be gram-negative, gram-positive, or anaerobic organisms. Assess the likelihood of antibiotic resistance. Again, if it's a patient that's been in hospital for a long time, think of hospital-acquired bugs. Review any potential contraindications, such as allergy or organ toxicity. Choose a drug with adequate target tissue penetration, and aim for a single drug with the desired spectrum of activity. So I just want to point out my source at the bottom there, that A Pocket Guide for Antibiotic Prescribing. It's really a short little book, but it was really easy reading and a lot of really good thought-provoking nuggets of information. So if anyone's interested, it's a great read. So then just to continue with those, so ensure the correct dose and the route of administration, start the appropriate antibiotic rapidly in severe infections, practice early and effective source control, evaluate antibiotic appropriateness every day, which they've then come up with these 4 Ds that you can see on the left-hand side. Sorry, it's not necessarily showing very well, but delivery, dose, duration, and de-escalation. So every day when you see these 4 Ds, so review if the IV indication is still there, or if you can switch the antibiotic to oral. So some specific infections will need IV administration, and then some contraindications to oral will be if they're too ill, poor absorption, or if they've been intubated. So just, again, to review delivery, whether you can switch to oral antibiotics, to look at the dose, is it, especially in our kids, is it correct for the weight, is it correct for the age, especially in the neonates where this changes from week to week, and are you giving it at the correct intervals? And then to evaluate the duration of antibiotics, is it appropriate? So brief guidelines for stopping antibiotics if the patient's been afebrile for 48 hours, if the white cell count or inflammatory biomarkers are improving, or if there's clinical improvement but not necessarily complete resolution. And then to consider de-escalation, so switch to a narrower spectrum of antibiotic according to blood culture results. And then an important part that I hadn't really thought about or included in antibiotic stewardship is infection prevention. So every time you see a patient, stop and ask, can I de-escalate these antibiotics or stop them? Can I remove any urinary catheters or IV lines or other sources of infection that might be there? And then, do these patients have a resistant bug that needs special precautions, such as contact precautions or air precautions? So then, to take us through our antibiotic guidelines, preoperative prophylaxis for clean operation, no antibiotic is needed. We're doing a longer operation, cefazolin can be given at induction and continued for 24 hours. If it's a dirty operation or bowel is entered, we'll give cefazolin and flagyl at induction and continue for 24 hours. And these can then be continued if systemic signs of sepsis present themselves. In neonatal surgery, we can continue antibiotics started by pediatrics. It's normally ampicillin or PNG, Genta, and flagyl. If the new sepsis develops, our second line is piptaz and amikacin, as well as the importance again of doing a septic screen and blood cultures. And then third line is our carbapenems or colistin, depending on sensitivities. In our burns patients, no prophylaxis is needed at the initial burn. Again, just to highlight the importance of doing pus swabs after dressing changes, and especially when we are preparing to graft. So if the pus swab grows Streptococcus or Pseudomonas, then it's not ideal to graft on, as the graft might fail. If the sepsis criteria that's met in our burns guidelines, if it's day 1 to day 3 post-burn, we can do cloxacillin, gentamicin, and ampicillin. And if the sepsis criteria is met and they're more than 4 days post-burn, we start them on amikacin and piptaz. So appendicitis patients we treat with ceftriaxone and flagyl. If it's unperforated appendix, there's no need for further antibiotics post-op. If there is slough found at the appendix, we continue the antibiotics until they are apyrexic for 24 hours, and then change them to oral antibiotics. And if it's a perforated appendix, we continue until they're apyrexic for 24 hours, and again change them to oral. And if it's perforated appendix with 4-quadrant sepsis, we continue IV antibiotics for 5 days. For skin infections, we've been using flucloxacillin, or at the moment cefazolin, because cloxacillin is out of stock. For our datitis, we give albendazole 10 milligrams per kg once daily for 3 months. Praziquantel's a continuous fight. And then for schistosomiasis, we can use praziquantel to treat. So the last little thing I wanted to touch on was the long-term outcomes of these patients that have suffered sepsis. So there are 2 studies. One is the LAP study. They looked at children from neonate to 18 years old. 18% of their children were immunocompromised, and 51% demonstrated chronic comorbidities. They did a baseline performance category on admission into ICU for these patients, and only 38% of the patients tested as baseline normal for their age at the beginning of the study. So it sort of paints a picture of the children that do very poorly with sepsis are often children that have underlying conditions or abnormalities. On average, the children in this study required inotropic support for 3 days and were ventilated for 8 days. 1 month mortality was 8%, and 1 year mortality was 13%. And 35% of these patients did not regain their baseline quality of life that they'd had before the sepsis. Adverse outcomes were associated with a longer ICU stay, longer time of ventilation and of inotropes, need for renal replacement treatments, episodes of CPR, and then the development of pathological and neurological signs. And then the other study was the SPROUT study that showed a 25% hospital mortality rate. Again, they looked at the same group of patients, neonate to 18-year-old in ICU with inotropes and ventilation due to septic shock. So they had a 25% hospital mortality rate. 67% of patients had multi-organ dysfunction at the diagnosis of sepsis, and 30% subsequently developed new or progressive multi-organ dysfunction. On discharge, and they followed up at 6 months, 17% had moderate disabilities and 28% had mild disabilities. So from these studies, we can see that even though they recover from the sepsis, it creates quite a knock in terms of their development. So it would be desirable that a multidisciplinary longitudinal follow-up should be coordinated for these pediatric sepsis survivors. And I quite like that. So these are all my sources. And then I just added a few resources. These were all the definitions for the ages. And then fluid and base inotrope management algorithm from the guidelines. These are it.
Kirsty, that is very exhaustive. It is very thorough. It's comprehensive. It's almost like writing a book. What what I would have liked is just you putting 1 or 2 slides with conclusions, because it's where you have studied a lot. You will remember most of it, but for the rest of us, a take-home message. I think you summarized in between after each sort of subheading, but at the end, I would have liked you to summarize in 1 or 2 slides. But this is very comprehensive, and this information should be shared. You can even put this PowerPoint presentation on our group, and it will be very useful for anybody reading and studying about it. I just like to start with Kululeko. Dr. Majola, if you have any comments about this.
Hi,
Yes.
Can you hear me?
Yes, we can hear you. Please go ahead. Yeah.
Yeah. Thank you, Kirsty. This was very extensive and informative. My sort of comment is, which we've always been more proactive towards, was using adrenaline or epinephrine from our side when it comes to our shock patients as compared to peds who like the butamine. So that shows, as you've seen with the studies, that adrenaline works much better initially, obviously with a patient who's in shock, because you can reverse the shock quite early or quite quickly. And then obviously if that's not working, then your sort of next line of an inotrope is something that has cardiac activity, which is then will be your butamines. But my important comment is, can you put back the slide on antibiotics, especially antibiotic use? I think it was appendicitis, if I'm not mistaken.
From our guidelines.
Yeah, from our guidelines. Yeah. So what I would like to stress with this, if we read through these slides, is the IV versions of all our antibiotics. They're given sort of a time frame. It's either the patient is apyrexial for 24 hours or they're tolerating oral feeds that you change them. What we do is we sort of keep them for too long on IV antibiotics, and we send them to CMH to finish IV antibiotics, which is not recommended. So if a child is getting well, they're tolerating oral feeds, and they're apyrexial, there's no need for us to keep them on IV antibiotics for 5 days as we normally do. So we can change them to oral versions of the antibiotics, and that also will also help us, instead of transferring the child across to another hospital, that we can get them home early because they can take the oral version of the antibiotics. So that's basically just my comment, that as we fast track them to getting them to tolerate orally. Let's also not forget to change the antibiotics to oral as well.
Yeah, it was a good reminder.
Yeah.
Like
All right,
it.
that's my.
Yes,
Yeah.
Yes, thank you. Those were very practical points. Kirsty, before I invite other comments, I just felt that our management of children with sepsis and septic shock is quite consistent with all the guidelines. So I'm quite glad that we are following most of the guidelines which you mentioned today or which you highlighted today.
Yes.
Yes. I'll just invite Yashoda to make comment or give her advice or opinion. Yashoda, please.
Yes. Hi. Thanks, Kirsty. That was really good. It was very extensive and thorough, like Prof said. So thank you for that. And for a reminder on surviving sepsis guidelines, because we all need a reminder now and then. So, I'm like a broken record about the immune system. I just want to add to that slide that you had on the immune system. It's very basic, and we've been taught in a very basic way, but we're starting to learn that the immune system is much more complex than we understand. So just like this whole COVID thing is unmasking, how we don't understand the cytokines and the cytokine response. There's many steps in the immune system that are missing in our understanding. And my big one is the microbiome. So and then that comes together with the resistance and surveillance and stewardship for antibiotics. So I just wanted to highlight that quickly. Then I just wanted to say about the adrenaline and dobutamine. Yes, adrenaline is better at first, but dobutamine might be good to add once there's a problem with the cardiac output. So you said it very nicely. The problem is with either the cardiac output or the systemic vascular resistance. And those are two different things, and they can be targeted differently. So adrenaline is good at first, but then you can add dobutamine later.
Yeah, Kirsty,
Yes.
I like this slide very much. Especially that semicircle. That's really very helpful. So I think this is one of your key slides, which everybody must remember, including me.
Sorry, I didn't have my notes. I just wanted to well, anyway, in the notes on the bottom here, does that dopamine 5 to 10 milligrams per kg is beta, and then 10 to 20 gives you the alpha 1.
Yeah.
So I've seen, because I know at CMH, the pediatricians that side use a dopamine dobutamine mixture. So they use dopamine instead of adrenaline, and then dobutamine for they use it as an alpha 1 adrenaline.
Yes, and I think that's fine, because the initial effects of the sepsis is the intravascular dilatation. So you're trying to vasoconstrict peripherally to increase the cardiac output. To increase the BP like that at first, but then you might have cardiotoxicity or a kind of cardiomyopathy from the sepsis, in which case you will need to add dobutamine to increase the cardiac output as well. So adrenaline is good to start with because of the intravascular dilatation, the peripheral vascular dilatation. So they do it well in theater. The anesthetists understand this a bit better. So they do it well in theater, and which is why I just wanted to bring it up, because what our pediatricians are doing is adding dobutamine first which I kind of disagree with. But we can discuss that with them. Then the other thing I was going to say was the HB of 7. I think that's very dubious to follow all the time, especially in neonates where the HB is supposed to be much higher. So I would individualize those decisions, especially in a neonate who is septic, who is tachycardic, who is tiring from the tachycardia. You know, you need to make a decision clinically. And I would argue, and it says weak evidence there for an HB of 7, which is quite low for a child.
Yeah. Yeah, I don't think it's targeted.
I think that was an adult, I think that was an adult recommendation. And I think there's weak evidence for a child.
Yeah,
Yes.
I agree, yeah. And we also transfuse.
I wouldn't.
Yeah, we transfuse.
I wouldn't wait for an HB of 7, yeah.
Yeah.
Especially with our neonates.
Yeah.
Who are septic.
Yeah.
And then we do have surveillance and stewardship at our hospital. We need to get on top of them more to give us the information that we need to change our antibiotics, to give appropriate antibiotics. It is very important, but I like that you mentioned animals because actually the resistance for antibiotics globally is coming from the animal industry, from the meat industry. So that is a very important point to bring up. Not so much from the health sector as it is from the meat sector, because they're using tons and tons of antibiotics for animals.
Okay.
I think that's all I wanted to say. But yes, we need to get on top of the Antimicrobial Stewardship Committee and see when they are meeting again.
Yeah. Okay, Yashoda, thank you very much.
Can I just?
Yes, yes.
Yeah, I just want to comment as well on what Yashoda just said. Just in brief, if sort of layman's terms, which something that I learned when I was still probably studying, is something called warm shock and cold shock. So your warm shock is usually what will respond better to adrenaline because you want to vasoconstrict them and get increased vascular venous return so that you increase your blood pressure that way. And then your cold shock is obviously someone who's already vasoconstricted, but you're still not winning. So that's when you add your cardiac active drugs, so your dobutamine. So that's why initially, yes, adrenaline is best to use, and then add on is something that works on the heart contractility to assist and get that cardiac output up and the BP up. And then with the HB, yeah, I think that's the 7 was, as far as I remember, that's for adults, but also that was also gauged on how sick the person is. So you would look at also the other markers or your vitals, if the respiratory distress and the tachycardias, if that's not also responding, then you will top them up to give so that you get better delivery of your oxygen to the cells with a higher HB. So I think with us, with kids, we've always sort of aimed at getting them above 10, because then we know that you eliminate all the other stresses on the system or the child with an HB that is a bit higher. But obviously it's not written down. But I think if I remember, which is working with PICU and the other centers, we've always aimed for an HB of 10.
Yes, I think that's what we all look at HB at 10 gram%.
Yeah, I think I brought it up again because, you know, it's in the guidelines, but also we've had patients where we transfused in the night because it was missed, you know, and low HB. And a low HB in a child or neonate with sepsis is, you know, it can it can really put a strain on his system, on his cardiovascular system.
Yeah.
So I think we must just be on top of that and not wait for 7. 10 at least, I would say.
No, thank you. We've got about 8 minutes. I want to invite Dr. Lazarus if he has any comments, and after that I would like to invite Cello. So we have about 8 minutes total. So Dr. Lazarus?
So I'll try not to talk for 8 minutes. Thank you, Kirsty. That was super. It was really comprehensive, and I think very helpful for all of us. Now, my question really is, or my thoughts are about this. Who are our patients dying of sepsis? So if I may, just for the sake of not taking too long about it, let's put the burn patients aside where sepsis comes and the patients basically begin to fade away after a while. Let us just go to the really major group of our patients who die, and who die of sepsis, are our newborns. And they are the newborns very often who have had prolonged management. So it'll be a gastroschisis patient for whom the bowel may or may not have been reduced, but we've been trying to do that, or we've got it in the first place, but they've not been able to take food enterally, so they've had an intravenous line. It's the patient with a small bowel atresia that we have operated on and waited and waited and waited, but food doesn't go through the anastomosis. We may have even redone it, and they begin to get sepsis. Now, my observation is that certainly in the public sector, we tend to wait a very, very, very long time to replace central lines. We replace them because the central line eventually gives up. And yet it is one of those principles that you introduced in your talk, that we need to get central line, we need to get invasive lines or tubes or whatever out of patients as soon as possible. And I think that I didn't hear an emphasis, which I think is so important, on our removing central lines far more early than the time that we often do wait for them to become septic and to be not working anymore. I think that more elective removal of them after a period is, and at the first sign of sepsis, is important, rather than getting them on Targocid and on a whole lot of further antibiotics. It seems to me that is a surgical statement we could make that might make a difference to our patients. My thoughts. Thank you.
No, thank you, Colin. That is very true. I think Yashoda also keeps reminding us about central lines, and we tend to leave them for long, but we need to be more proactive about it. We can continue discussion in the next meeting, but there are about 4 minutes in this meeting. Cello, I know you could only join a bit later, but I would like your comments about this, and we can continue discussion in the third meeting, at least for a few minutes if required. Cello?
Yeah, hi, Paul. Yeah, thanks, Kirsty. Quite comprehensive. I only saw the second half shame of the presentation, unfortunately. But I have nothing relatively new to add except what everyone is saying. But the transfusion triggers it's one of those things which is always for debate. You can have a child who is on room air with SATs which are 100%, but the HP sitting at 7. Or you can have a child who is ventilated and is sitting with an HP of 7. Obviously, you want to optimize the oxygen carrying capacity of the ventilated child with the low HP versus the other one who's relatively comfortable. But ultimately, you don't want to leave it low, but you have to individualize each patient as to what your trigger is for transfusion. And it's always changing every single day, whether it's these kids or even burns kids. So it's always a dynamic process of when to actually start. And with antibiotics, like I have a different way of dealing with, let's say, kids with appendicitis, for instance, because my rationale, the second the child can eat, can actually tolerate feeds, that means that you can obviously start oral antibiotics. But the main reason why I would still suggest us to continue the antibiotics for this period of time of 5 days is not that we are trying to make sure that we covering sepsis per se, because they can tolerate and it has good penetration, but to make sure that we still monitor the kids and make sure that they're still in the hospital, because as you know, they can complicate on the day 5 of antibiotics, and should we discharge them slightly earlier than we should have on day 2 or day 3, and they go very far, they go to LUL North, they'll come to us later on in a week's time, and it would have complicated further. So I think for our setting, keeping them slightly longer for that 5 days is not necessarily just to give them IV antibiotics, but just to make sure that they clear that initial hurdle of sepsis from perforation. And with appendicitis, as you know, it's a whole discussion on its own about antibiotics, because you can even give single agent antibiotics. You don't have to give quite a lot, and even simple augmentin has been shown to cover, could give adequate cover for the type of organisms that we're growing when you have a perf appendix. But ultimately, I think even with the discussion about adrenaline, dobutamine, every single year you find that, especially even when you speak with different pediatricians, you find that others prefer adrenaline, others prefer dobutamine. Fair enough. Evidence suggests you start adrenaline first, which is what we routinely do. But as you're saying, like it's not level 1 evidence. If I'm up for correction, but especially with the sepsis guidelines, most of the things is the regarding epinephrine or adrenaline versus dobutamine was not level 1 evidence. I think it was level 2 or something. But my point is that depending on which pediatrician or which physician you're dealing with, they have their own preference and their own reasons for adrenaline over dobutamine. And as Yeshua was stating, the anesthetist, they may have a better understanding at on a more physiological level than the pediatricians, hence why they choose to give certain inotropes versus others which the pediatricians prefer. But I think ultimately it's just do what we are used to. Don't try to create new things. So we still prefer adrenaline and add